Tanse from the First Nations Health Managers Association, broadcasting from unceded and unsurrendered Algonquin territory. My name is Marion Crow from the Pie Pot First Nation in Saskatchewan, now serving as the privileged position of Chief Executive Officer of the First Nations Health Managers Association. I do hear a tiny bit of feedback in the background. I think somebody's probably not muted, so a little, there we go. And I just want to take an opportunity to thank each and every one of you for letting us come into your nations, your homes from all across Turtle Island. And we have a really informative, as always, jam-packed town hall giving you the credible, relevant, and reliable information. So if you have a question, now is the time. Everyone, get excited. We have not one, but two Indigenous physicians joining the FNHMA Town Hall today. We're welcoming back who you all know and love, Dr. Evan Adams, our partner at Indigenous Services Canada, who shares all those epi-stats with us every week, and brand new to the FNHMA Town Hall, but not new to my heart, is Dr. Shannon McDonald with the First Nation Health Authority. And Shannon and I are going to be forever friends because we both know where the bodies are buried. That's the kind of friends that we are, folks. So go get your bologna and bannock sandwich, keep the radio station dial where it is, and let's get comfortable and have a discussion on COVID-19. With that, I want to thank Pascal Belanger. Merci beaucoup, Pascal, for making sure that we are being able to hear this in French as well. And of course, to everyone that you don't see that makes this successful, John, Chris, Stella, the other Chris, we love you at Nation Talk and Indigenous Health today for ensuring that this goes out. One final thing is if you do have a question, now's the time. Send it to FNHMA at ihtoday.ca. So let's roll up our sleeves and get right in. Welcome, Dr. Evan Adams to the FNHMA Town Hall. Hi, Evan.
Hey there, how are you?
I'm great. What do you got for us today?
Gosh, it's surprisingly good news as far as the number of cases on reserve in First Nations. I wonder if all of you have heard about the third wave. We had our first wave in April, our second wave at the beginning of December, and we're just coming off of our third wave. We also call it the New Year's wave. Numbers, so it peaked, but numbers have been dropping since the beginning of January. It doesn't mean that we need to, it doesn't mean that we can let up. I think we still need to be strict with ourselves, but it is nice to have the numbers come in and to worry a little less our actions as heads of households, as leaders, as healthcare workers has been helping. So the case rate, though, for First Nations on reserve in Canada is still about 1.6 times the rate of other Canadians. We did really well at the beginning, in March, April, May, all the way until August. Our case rate used to be 1/4. Yep, it used to be 1/4 the rate of other Canadians. Now we're at 1.6, but our hospitalization rate is only 60% that of other Canadians, and our case fatality rate is only just over 1/3 the rate of other Canadians. So even though we get COVID more often, we do better than the general population. So we'll come back to that. So the total number of cases of First Nations on reserve across the country is just over 17,000. The number of new cases yesterday was just over 100. New recoveries are outpacing new cases. So yesterday our new cases were just over 100, but our new recoveries were over 350. So that's why our active cases, our total active cases, are dropping and dropping and dropping. So the number of First Nations active cases across the country is just over 1,800. Of those, almost 800 of those are in hospital. So those represent, severe cases, because it is possible to only have a mild case of COVID, but there can be more severe cases. So hospitalizations of First Nations on reserve is almost 800, and our deaths since last January, it's been a year now, is at 172. And remember, these are just on reserve cases. They don't. I don't have numbers for those of us off reserve, including Métis and Inuit. So the number of Indigenous cases over time has really been dropping. In the second week of January, the total number of cases, active cases, were at 4,200. And then they dropped the next week to just over 3,700, the next week to just over 2,400. And as I said, this week, just over 1,800. However, we're not quite at the end of this week. The end of this week will be in 2 days. So the most number of cases are still in Alberta and Saskatchewan and Manitoba, but amazing to see the drops in those provinces. And then the fourth number of cases in BC. Shannon, my colleague, will talk about that maybe a bit more. And BC has the ability to count off-reserve cases, which is phenomenal. I wish we had that in every province, region, and territory. So yeah, a big downward turn. However, of course, the total number of communities that have had clusters is now 395 of our communities out of about 650. So that represents now 2/3 of First Nations communities in the country have had clusters and cases, including almost 96% of First Nations communities in Alberta, 84% of First Nations communities in Saskatchewan, and 92% of all First Nations communities in Manitoba have had cases. So the age group that's most affected for us as First Nations on reserve is ages 20 to 29. The second most affected age group is 5 to 19 years old. That's maybe why we're doing so well. Like we have more COVID, but we seem to have better outcomes. It might be because of us getting it at younger ages. The third most common age group to get COVID for us is 30 to 39. And then 40 to 49, 50 to 59, and over 60, they're equal, about 15% of cases. So that's kind of the view from here. And I'm hoping that the pandemic is bringing us together and not tearing us apart. And I think that goes to vaccine rollout. We're hoping that wherever the vaccine is being rolled out, that the commitment to prioritize Indigenous adults in all provinces and territories in the first quarter will be honored. So far, Canada has had almost 1.2 million vaccines delivered to its citizens. And even though there's been a blip in supply from Pfizer and Moderna in the last few weeks, and there have been some adjustments to the schedule that we were on, we're still hopeful that we can meet our targets that we set early in the year for the first quarter. So we were a bit nervous there for a while. Seems to be getting better as of the last couple of days. It's terrible watching the flow and the production line and having to adjust because we want our families to be protected. I live in my community. It's not quite on reserve. We have a treaty, so we don't say we're on reserve. I live in my territory, and I can't wait for the vaccine to get here and for especially the elders and the knowledge keepers to be vaccinated and to worry about them a lot less. So let's talk about vaccines and everyone getting vaccines a bit later on with Shannon, okay? that's it from here. Thanks.
Well, thank you so much, Dr. Adams. We always appreciate what's happening, across Turtle Island with COVID-19 positive cases, now some excitement and enthusiasm in terms of the vaccine rollout. I know we're tracking the vaccines. It's almost like watching Santa Claus on Christmas Eve across the territories, across our nations, and we're all excited for when we get to see those vaccines come. And really, it's the vaccine that I call Santa Claus now, because I'm so excited for the eve of when I get that call myself to go get the vaccine as well. You'll be hearing me shout bingo in Vancouver, I swear, when it's my turn. So thank you again, Dr. Adams. And as always, you know the drill. We'll go to the inbox a little bit later. So please don't leave us, because there are some questions for you, Dr. Adams. So thank you so much. Now, just before we get over to our next guest, I do want to just say a quick hello to a couple of folks. Thanks for tuning in to getting your COVID-19 information here from this trusted source of subject matter experts that we bring together so that we can all benefit from not just their knowledge, but their inherent knowledge in how we weave together Western and traditional practices. That's what makes this program very unique and special. I do want to just say hello, Freddie, watching from his Cree Nation, Tanse, and also Glennis. Thank you so much for giving all the hand claps and the love. It comes right back to you, Glennis. So thank you very much about that. And George, I love the George Linden, your comment to won't tell Dr. Adams that I'm more awesomer. Awesomer is what you said, George. So thank you. But now for the awesome-est, we're going to go to Dr. McDonald right after we have a message where it's another avenue. Your toolbox is getting nice and full with information, with tools and products and amazing resources that you can get COVID-19 information. And why don't you give InfoPoint a call? And with that, let's hear from InfoPoint. Over to you, Chris. Created by your First Nations Health Managers Association, we introduce InfoPoint, a convenient and accessible helpful desk for First Nations health managers looking for credible sources of information on COVID-19. Don't have time to dig? Talk to a real person now at 1-855-446-2719 or email infopoint@fnhma.ca. Indigenous Health Today is another resource of information by region at ihtoday.ca. All right, folks, you know how to get more resources. Again, give InfoPoint an email or a call. And a really special shout out to Kathy Mitchell, who is answering those phones, collecting your emails, and we'll get back to you shortly with the reliable information that you need. So again, thanks, Kathy Mitchell, for being part of the FNHMA family and serving InfoPoint. Now, over to the woman that I have been waiting for to come to the town hall. I know you're super busy, Dr. McDonald, so your time with us is so appreciated. Welcome to the FNHMA Town Hall. Shannon, come on in.
Thank you. I'm very excited to be here. As you may have guessed, folks, Marion and I go back a long way. Oh dear, my computer just decided to quit on me. My apologies.
No worries, Shannon. You'll get that. Or you're good? Okay.
Yeah, Shaw went down nationally yesterday and caused us no end of trouble, and I'm still trying to pick up the pieces. So I am the acting chief medical officer at First Nations Health Authority in BC. I'm coming to you from Sayut First Nation, so just up the peninsula from Victoria. I'm honored to live here as a guest. My roots are actually in the Red River Valley. And greetings to my friends and family from there who I don't get to see these days because of travel restrictions. So First Nations Health Authority has a very unique role across the country in that we serve all 203 First Nations communities in BC, and we've been very busy doing that in the context of COVID. So just to give you a sense of where we're at in terms of what Evan has shared with you, what Dr. Adams has shared, our first cases came last January. It's almost exactly a year ago. It was January 28th. Since that time, we've had over 4,000 of our First Nations community members diagnosed with positive cases of COVID. And as of yesterday, we have over 50 people who have passed. And when people start talking about the numbers in the country, the numbers are huge. But for the people in our communities, those numbers are their loved ones. They are their cookums and their mushums, and their leaders in some cases. There have been huge losses, and it's been particularly difficult for people in our communities because the traditions in how you say goodbye to your loved ones, how you do that in ceremony, have not been accessible. So people have really struggled with making that happen. As Dr. Adams mentioned, we have numbers for both on reserve and off reserve. And at this point, we have about 700 active cases, and it's about half and half. Half of those cases are people who reside on reserve, and about half of them are individuals who do not. But that's a big shift from the first week of January. We had about 1,000 active cases. So we've seen those numbers come steadily down, which is really good news. We received our first vaccines on December 28th, and were given 24 hours to come up with a plan. It was a bit of a panic. And we had to make decisions about how to prioritize communities and people. And we started with our most remote communities for our nursing stations, who over Christmas would have 24/7 nurses. Many of our communities, of course, the health centers closed down over the holidays, so it would have been much more difficult logistically to get things ready to go. So we started with those remote nursing stations. And since that time, we have put about 14,000 vaccines into arms in BC, all over BC, in 82 communities. And by the end of next week, we will have provided immunizations in 107 communities. So it's been a lot of work. There's been layers and layers of people who have worked very hard to make that happen. The provincial partnership is strong. We have a provincial commitment to 50,000 cases or 50,000 doses by the end of March. So that'll be a significant effort, but I think we'll make a significant change in terms of the number of cases that we have. So I'm just going through the details of what I'd hoped to say. There we go. So understanding that the First Nations Health Authority is a value-based organization. We talk about respect and discipline and relationships, the importance of culture, but also excellence and fairness. So it has been very, very challenging to set these priorities. Who gets the vaccine first? Respecting and acknowledging our elders, our language holders and knowledge keepers as being important in that. Acknowledging the role of community and making decisions about what's right for their community when vaccine reaches the community. And not wanting to be, to be without prejudice for First Nations interests. So we have some modern treaty communities like Evans, where They have an opportunity to work with the province directly to receive vaccine if they so choose. And we're not going to get in the way of that. That's up to those nations to do that work. But our most important piece in regard to this is functioning at a high operational standard. So making sure that all of the people doing the immunizations are qualified and certified, and that we are assured of the safety of the vaccines, and making sure that people get it in a timely way. So one of the challenges we've had, of course, is the fact that we're doing this quickly in 200 plus communities. And we want people to understand that this is not a mandatory vaccine. This is the choice of people to choose to have vaccine or not to have vaccine. But my job and the job of my colleagues is to make sure that people have the right information to make that choice. And there's lots of information out there, good information, bad information, false information, and really helping support people understand where the good information is, where that trusted source is. And we've worked hard to be part of those trusted sources, as has FNHMA. We want to make it clear that there are credible sources out there and what to look for. The other thing that's been really interesting and I've loved is communities telling their own story. And if you look at the FNHA website, there's quite a few pictures of elders receiving their vaccine and telling the story about why it's important to them to do it for themselves, for their family, and for their community. So again, making sure that First Nations are informed of the decisions they have to make. One of the things that we found is that key stakeholders, leaders, health providers, and others are so overwhelmed with the amount of information that sometimes they need help to dig through it, to figure out what's really important, what do they need to know now to do the job. That pace of new information is phenomenal. And I've heard lots of people express frustration saying, that isn't what you said 2 months ago. Yeah, I know. I remember in the early days where we thought, no, masks aren't important. Well, it turns out masks are important. And not only, but we have to be able to explain why that information has changed, what evidence has come to the fore that helps people. We also have to acknowledge our colonial past. We have to be able to say to people, you may have mistrust in institutions, in government, in health service delivery organizations, in science, in research. I absolutely understand and acknowledge that that might be the case. And so we need to walk through that with people to help them understand and to acknowledge that that may mean they don't make a decision to be vaccinated today. But what we have been able to do and are working to do is when we're in the community the first time to give dose 1, if people are reluctant or hesitant, to work to give them the confidence so that when we come back to the community, they're more willing and able to say yes. So we have worked really hard as well in terms of social media. I hope that some of you have taken a look at fnha.ca. We have a very active communications department who not only provide information at a community level, materials, resources that can be shared at the community level, other resources specifically for healthcare providers. We do a lot of work with media. I've been on TV way more than I ever thought I was going to. This is not what I trained to do, but I'm learning. But we also have a very vigorous process for review and approval of those communications so that our leadership know what I'm going to say before I say it. And so there's no surprises, because that's always been a bit of a challenge. We have reposted credible information from government sites or from scientific sites. And we work to translate to language that can be used at community levels, because that can be a challenge as well. But I really want to acknowledge and celebrate the community successes. That's where the solid work is getting done, where people at the community who are greeting people coming in to clinics, who are preparing clinic spaces, who are providing food and snacks to people after they have their vaccine. All of those are important parts of this process. And we've been identifying those champions as being a huge role and a huge support for the process. And we really want to amplify the messages that have been developed by the nations for the nations. The other thing that we've been doing is, like we are doing today, is having online webinars regularly with leaders. We try for the communities that are anticipating the next allotment of vaccine, their leaders and healthcare providers will be welcomed to those webinars to be able to have conversations and prepare them by answering their questions so that they can answer the questions and making ourselves available as much as possible. So I strongly thank all of you and encourage all of you, because I know you're all going to play a role and you're all going to be those champions in community. And I really hope to hear your stories to be able to share them. So thank you.
Dr. McDonald, thank you so much again for sharing the really hard work of the First Nation Health Authority. I know when we refer people as well, when calls and emails come into the FNHMA info point, FNHA is always at the top of the list for some of those credible, reliable sources. And the work that you're doing around vaccine confidence has been spectacular. Much like I've referred already to NAN and, looking at the vaccine as a box of matches, and you wouldn't go into the woods without the matches. These are all things that we can relate to, not just as Indigenous nations, but we have a lot of non-Indigenous Canadians who are listening and tuning in every week for this information as well. And on that note, we do have a busy inbox. So thank you so much for everyone who gets those questions in. Again, you can send that question to fnhma@ihtoday.ca. So if we don't unpack your question today, we might do it on a future town hall with a different speaker. So don't worry, we see it, we see you. Yvonne, hi, I know you're watching, and Judy from Saskatoon, thanks for tuning in as well, whether it's on the radio or if you're watching this online. We really appreciate that this is the place for information. So let's get some of those questions answered. Shall we do that? I'm pulling up our inbox now, and I just want to take a look at what people are asking about. So I'm just gonna, if you want to go back and forth, or whoever wants to take the question, please feel free to jump in and add to each other. So there is a question. Number one is, I've heard of employers making the vaccine a requirement. Can they do this? And am I required to get the vaccine? What are your thoughts on this? And I know we get into the provincial regulations and stuff, but what are your thoughts?
We're both going to be polite. I'll just start. The vaccine is not mandatory, but employers can sometimes push the envelope a little bit. What we have recommended to employers that have asked is, if people choose not to get the vaccine, then they must continue in all circumstance to follow the public health recommendations. So wearing a mask, washing their hands, protecting other people, or maybe even adjusting their work so that they're not face-to-face with clients or patients or whatever it may be. But at this point, there is no requirement for vaccine that I'm aware of in Canada. Evan?
A little, sorry, I had a little bubble pop up just as I was hitting the unmute button. No, it's not a requirement that I've heard of from any employer. I'm assuming that there may be discussion eventually around there were the beginnings of requirements for healthcare workers to have certain vaccines as a condition of employment, but that was a discussion, and that's only for a very specific subset of healthcare workers who have direct contact with patients. But that is not, that was about other vaccinations and not about this vaccine. So yeah, definitely it's not a requirement. In fact, we're telling people this is your choice, but
Yes.
we would like for you to discuss with us, especially if if you're deciding not to, because some people are saying maybe I'll do it in a month, and we'd like to talk to you about that. If especially if the vaccination is only here today, and we're not planning on doing vaccines next month. Like, do you want to hold your place in line? Are you okay with going to the back of the line? What do you need in that month to make your decision? And those kinds of ideas. So talk is cheap. People should be able to discuss with us. And I'm having lots of discussions with lots of stakeholders. Like, for instance, my niece who's still breastfeeding, or my other niece who's pregnant. Having a discussion around the pros and cons of vaccine.
Yeah.
Thank you so much. This is a dialogue. We want to unpack your questions. Everyone has questions. It doesn't matter if you're somebody's cook of mushum, if you're a frontline worker, if you are a health director, health manager, anyone in the whole general population has got questions. And the one that I want to pose to you here, because no question is ever dumb. There are some reports that we're seeing in, say, the Washington Post and Global News talking about anal swabs. We heard that China's #2 method, and I'm sorry for everyone who's eating that bannock and bologna sandwich right now. We're just taking a quick detour and just put the sandwich down for a minute. Anal swabs. Is this something we'll consider in the future? What are your thoughts on that? Who wants to take the bum question? I know, only on the FNHMA town hall, folks.
Start, but I'm very. I think a lot of doctors are very unsympathetic because it's not a big ask. If it was ever here, and believe me, I've not heard of the anal swab being here yet. That, to me, that's not a big deal. Just like when people say to me, "Oh my gosh, that needle! I'm so scared of needles." And I think, are you more scared of a needle than a stay in the ICU? To us who give vaccinations, a little poke in the arm is just such a small ask. Just like wearing a mask. It's just, how can we ask so little from you for such big returns? So so I'm not sympathetic, but let me repeat, I've not heard of the anal swab in Canada for COVID testing.
Nor have I, and I can understand why, if there is a patient who's unconscious on a respirator or in other circumstances where a nasopharyngeal swab might be a challenge, I can understand why caregivers might resort to an anal swab. But at this point, it doesn't make any sense, and it sure increases the need for privacy around getting a swab. So at this point, not that I'm aware of.
And thanks for asking this, because I don't know how to talk about things like the nasal swab or the throat swab. I've heard so many people say, "Oh, I can't do it. I can't do the nasal swab. Oh, I might choke a little bit with the throat swab." And you can hear from my voice that I'm not very sympathetic. It's like, come on, man, let's all be a little tougher. You're gonna be fine.
We are Indians, people. We have conquered much worse. So, as Doc said, it's not a big ask. He didn't say the other word. I saw a comment come in. It's not a big ask. Put your mask on. If you have to get a swab, just Tough it up. Okay, that's all I'm going to say about that. Moving on from anal swabs, and this is part of why people tune in to this information session, is because we also appreciate that laughter is medicine. So a little giggle here and there makes that medicine a little bit easier to take. So we will continue to laugh and appreciate the small joys and laughter when the world feels bleak and isolating. Tune in here and we'll make you smile. At least we'll give you the bad news with a smile. And I know NCI Radio, you guys are the best. And you always say, if there's bad news to be had, Marion, can you deliver it with that calming voice and laughter at the end? So, all right. Let's go to the next. Let's talk shortages of COVID-19 vaccines in Canada. The people who got the first dose of the vaccine, are they able to get the second dose within the required time frame that some of those vaccines have given parameters around? If they don't get the second dose in time, would the first dose have to be administered again? What are some of your thoughts on that? And I know that this is also a provincial discussion as well, so I appreciate that. But what are your thoughts on some vaccine shortages and getting that second dose?
This is one of those changing science questions, right? So when the vaccine first came out, the recommendation from the manufacturer, both Moderna and Pfizer, talked about second dose within 21 to 28 days of the first dose. So 3 to 4 weeks. In the interim, 2 pieces of work have been done. The scientists have checked to see how effective that first dose is. And originally, we heard that it was around 70% effective. Now we're seeing numbers up to 92% effective. With that in mind, and with the shortage in mind, decision in BC has been to extend that second dose timeline to 42 days. So looking at 7 or 6 weeks to 7 weeks as being the recommended second dose timeline. The question about if you don't get the first dose in time, do you have to get the first dose again? And the answer would be no. What we don't know is how long our immunity is going to last. And it's assumed that the second dose will provide a longer period of immunity. And right now, the statistics are looking like 95% and above effectiveness after the second dose. But there hasn't been enough people here who have gotten the 2 doses yet to really get a good sense of that. But in the UK, where there's been 10 million doses given, the numbers are coming back great. And in Ireland, they're leaving the second dose as long as 12 weeks after the first dose. So there's lots to learn. There's lots more science to be done. And Evan, maybe you can speak to sort of the federal view on this.
Sure, yeah, it's too bad that this question was forced because of the supply being a little bit difficult for the last few weeks. But it was a really good question in that initially there was the thought that maybe we shouldn't hold back the second dose, like put it in the fridge, so that we could deliver the vaccine perfectly on day 21 or day 28. Like we did some modeling and it was very clear that it's better to have as many people possible having a lot of protection with the first dose than having some with nearly perfect protection because they had those in a fridge. It was just way better not to have product on a shelf waiting for delivery into an arm on day 21 or day 28. So now the supply is pushed the question even further. Can we go past day 21, day 28? Had lots of questions on that. One person said, isn't it like antibiotics? And like antibiotics where you have to finish the dose or else you get into trouble? And I said, no, it's different. With antibiotics, they have like a half-life of 12 hours. And so, you have to get the next dose like perfectly on time, your immune response to the first dose is actually quite good and seems to last for an extremely long time. Like we don't even know how long it lasts because it hasn't been that long. And the second dose, so the reaction to the first dose is excellent. And the second dose is really just a booster to get you from, the 70% to, about 95%. So, and it seems that we can extend, and we're checking how long we can extend past the 21 and 28 day. And depending on where you are in the country, every province has got slight variation. Some are saying we will deliver it, within day 42. Some are saying day 56. Some are saying within 3 months. And some are saying we're going to do it perfectly. Like we have the ability to do it exactly on day 21 and day 28. But those are usually the smaller jurisdictions. Anyway, that's a lot of talk about how long you can go and wait for the second dose when a few of us haven't had the first dose yet. Thanks.
This is why we have these dialogues, though, right? These are the questions people want answered. And I am just so happy to share information that is going to help keep us protected, but not just us. I mean, let's come back to our Indigenous values about thinking about those 7 generations ahead of us as well, and who we're protecting by acting in a unified way, just like our values teach us to look after the whole community and nation. So I do value all of those 7 teachings and think about those when we're discussing health outcomes. Now, another question from the inbox, and we're not going to talk anal swabs anymore. I just had to say that again to wreck everybody's lunches. Sorry, it's making me laugh and giggle like I'm a 12-year-old. Let's move over. We were talking about some of the if somebody has an adverse reaction, so for example, this person suffers from seasonal outdoor allergies and is wondering if any of the ingredients in the vaccine could give an adverse reaction. And they've heard on the news in the past that people with allergies should not get the vaccine. Or is the allergy warning for people with allergies to forms of medicine? So a lot to unpack in there. And of course, we always preface everything with talk to your public health official. But what are your thoughts on this, Dr. Shannon? Oh,
Evan first.
Sure. Actually the direction is to have caution when someone has demonstrated severe reaction to any of the known ingredients in the vaccine, or someone with severe allergies in general. So seasonal allergies or a runny nose in the springtime is not considered a severe allergic reaction at all, and you are able to get the vaccine. But good question, because if you have any concerns at all, you should check with your doctor before you go to the vaccine center. Like, try not to hold up the line and say, oh, but I have a question. Those questions will hopefully be answered there. Remember, the vaccinator is not necessarily there to try and stop you from having a vaccine, for a full-on assessment, and you'll have done that. So really, the bottom line is to measure risk versus benefit. And we're starting to be a lot more confident as we watch severe adverse reactions that there's usually more times than not much more benefit than there is risk. Even something like a severe reaction like anaphylaxis is treatable. People can go home quite quickly if you catch it and you treat it. Like with an EpiPen, someone with a peanut allergy doesn't necessarily go on to severe complications. Their anaphylactic reaction is just dealt with, and they can go home. That's pretty cavalier. I'm not suggesting we should all put ourselves in front of a potential anaphylactic reaction, but most of us won't have that, and most of us will have had some kind of hint that we could have that because of previous exposures to other things.
Yeah, thanks, Evan. One of the taglines that we've been using in our vaccine confidence work is it's always safe to ask. So really recommending to people that, give your doc a call. Many of the provinces have a nurse line. In BC, it's 811. You can call and you can talk to somebody and ask the question. The people we're most concerned about, of course, are those people who have a history of severe reactions. But we know that both the Moderna and the Pfizer vaccine have very few contents that people have been allergic to. So there is the messenger RNA, so the active ingredient, and some other lipids, so fat-like substances and buffers like salt and water, and one other chemical called polyethylene glycol. And it's a very common ingredient. It's in makeup, it's in laxatives, it's in all kinds of things that people take normally. So sometimes people look at the ingredient list and get a little concerned. What is that? And what, am I allergic to it? It's very rare to be allergic to it. So generally, if you have mild allergies, you should be just fine. But if you have more severe allergies or you take regular medication for your allergies, it's good to have a conversation with your healthcare provider.
Thank you so much for that information. There are a lot of questions in the inbox that relate to culturally appropriate messages in ensuring vaccine confidence. And I know that there is a level of trust that has to happen with that healthcare provider and confidence between the vaccinator and us as Indigenous peoples. I mean, we have a lot of non-Indigenous Canadians who have tuned in and who are watching and listening, and for our own nations. Why are the messages so important about vaccine confidence? Why are Indigenous people asking about this over and over? Now, reminding everybody, we just came out of last week 2 days of dialogue about how, I'll get angry. I've been laughing and now I'll get angry, but about the deplorable places people have been put in harm in the healthcare system and the movement that leaders are trying to get to with ensuring that we are not afraid to enter the health systems. Do you want to talk a little bit about why vaccine confidence is so important with Indigenous people, especially in this landscape of racism? That's a loaded topic. So,
Wow.
yeah, Shannon, come on, jump on in, lady.
And Evan, please. I think a lot of people are unsure about vaccines. It's something foreign that we're putting in our body. What does it mean? What does it do? And I've had lots of questions from people who have received tons of misinformation, that it's going to make them sterile, that it's going to affect their DNA, that, there's a lot of misinformation out there. And we've been able to provide information for people that disarm those fear-mongering statements. But nonetheless, as I said earlier, we still have to acknowledge people's experience. In the community here, I've had people who were day school students or residential school survivors who have really horrendous experiences in their lives. Trust is a difficult thing for them. We have had people who have had negative experiences or been fearful going into the healthcare system because of what they've heard or what others around them have experienced. And we've talked, or I have talked to many of those people here, that if they want me to go with them, and I'm sure there are lots of others that would volunteer to do the same kind of thing, to bring a friend, a family member, somebody to be your witness if you think something, if you're worried that something bad is going to happen. But I think my experience has been so far that people have had really good experiences, because a lot of our vaccine activity has been in community with community members around. So just, I don't want to say to people, no, it's not true. No, it's not going to happen to you, because I can't guarantee that. But what I can guarantee is that there's people really working to change that. And that if you need to bring a support or a witness with you when you receive care, then go for it. Evan?
Yeah, I've heard a lot of people say that they, just in general, going into the care system, they go there seeking help, but they end up having a colonial experience where someone demeans them, disempowers them, is aggressive towards them, dismissive. And they don't want that. So sometimes they just would prefer to stay home than to seek help within the system. And some people, I think, are just less trusting because life has shown them that, certain institutions are not trustworthy. But, this is a worldwide pandemic. Disinfection's pretty bad. And maybe this isn't about those past traumatic experiences. But if it is, like if people are having a bad time, then we'd like to hear about it. We want those stories. We want those testimonials. We know, in fact, that if people are having a bad time, first of all, we need to do something about it. Second of all, Shannon and I are not trying to sell a vaccine at all. We're trying for people to be well. So if the vaccine experience isn't good, then yeah, absolutely speak up. But I'm not hearing very many stories about people having colonial experiences, but in part because we're working really hard to have our own vaccinators. So it's safe for our people, and most of the people they'll see will be very sympathetic, or maybe even our own people will be vaccinating us. And it's tough. Like for instance, in one city, and I hope we'll talk about city vaccinations or urban peoples. In one city, in the inner city, where we offered COVID vaccine, the trust was not good. A lot of people said, we're not sure about you. So the relationship needs to be there, first of all. But for those of us who are living in communities, I think the potential for a really good experience is great. And I love, Shannon, the elder video that y'all posted of, was she 95? She said, this is good. And you just have to hear her. She's phenomenal.
You know what? That is, I always have to remind myself to unmute myself because, we have 15,000 people watching and listening right now. But you know what? We are not here to sell vaccines. We have no ownership, no stake. Our job is to provide reliable and credible information to assist in informing your individual choice. At the end of the day, we want you to have the information. As someone who has been in health for a number of years, more years than I would like to admit, it's a choice, and we want to give you the information so you can go in with an informed mind and take away the myths and some of the rumors that surround that. Let's talk a little bit then now. And Dr. Adams, thanks for bringing up a point that I wanted to get in. I know there's a lot of questions for folks who are hesitating in terms of the on reserve populations. So we want to hear what's happening for our off reserve populations in the cities like myself, who are waiting. I'm not living in my nation of Pye Pot First Nation in Treaty 4 territory. There's a commercial. But we're going to have on Jocelyn Forsma, who is the Chief Executive Officer at the National Association of Friendship Centers. And she's going to dive into the discussions about all of us who are off reserve. And we're going to talk too about some of the mental health and underlying issues, especially when we have vulnerable, and this isn't my word, I don't use that word, but it's in the inbox. So those folks who are wondering about mental health, vulnerable populations, some of the homelessness that's happening in the cities, we're going to unpack that in great detail next week with Jocelyn. We also have Valerie Gideon coming back to the town hall as well. Some more trusted and credible sources of information for you to hear from. So I know we're getting close to the end of our hour, but I think what would probably be good to put out there is a reminder about what herd immunity is in relation to COVID-19, and what does it mean to have herd immunity? Can somebody unpack that for us? And I know it's a question we've asked to Kim Daly before, so I'm glad people are asking the question. Herd immunity, what is it? Why do we want it? Do we want to achieve it? And what constitutes a cluster?
Evan, it's your turn to go first.
Sure. So herd immunity is when there are enough people who are immune to an infection that they're not passing the infection on to others. So others who may not have immunity are protected. But that's a pretty high number in a population, like a significant proportion. And I've been hearing about it with COVID, and that some people are saying, let as many of us get COVID so that our body learns immunity. And then then we don't have to worry about it. However, that's just a way of saying, let's just do nothing, let everybody get it, and some of us will die, and then we won't have to worry about it. But that's not a plan. That is not a good way to go. It's better for us to do as much as we can, and try and achieve herd immunity through vaccinations rather than just letting things go loose and sit back and hope for the best. I hope that helps.
It does. Scary thought. Remember that viruses can't replicate themselves. They don't have DNA. So they can't make a copy of themselves. And every living thing wants to make copies of themselves, have babies. Viruses need a source of DNA, us, to replicate, to make more viruses, to spread to other people to make more viruses. And if they don't have anyone to go to, that can create herd immunity. So if everybody in the community I live in was vaccinated and somebody came in as a visitor and were infected and could potentially infect everybody, but that virus had nowhere to go, there was no susceptible human that was available to be infected, that would be herd immunity.
Wow, lots of information in this jam-packed hour. I certainly appreciate the candid and frank and honest conversation that we were able to have. And to everyone who sent in a question, we will bring these questions back. This isn't our first dialogue. It's going to be one of many. I know that FNHMA is committed to coming back for a fourth season come April, because we know we're still going to be talking about COVID-19, new variants, and what does that mean for Canada? Should we be doubling up on masks? Do we need to, what does that mean for us in our everyday lives? So keep tuning in here to get reliable sources of information. We appreciate and value all of the questions you have. And just for one last time, we'll ask about anal swabs when no one else will. That's my job. I give this to you. With that joke out there, I will now go over to all of those radio stations and websites that may not broadcast us anymore because of my distasteful humor. But I do say, as always, thank you, Micmac Maliseet Native News in Nova Scotia, The Wolf 95.7 in Fredericton, Nation News in La Belle Province in Montreal, Element FM in Toronto, and here in Ottawa, unceded Algonquin territory, NCIFM. I know I go on about this radio station all the time, but Davey, Jordan, Garth, thank you for giving me light every Thursday morning to talk about what's coming up on the town halls. I love NCIFM. I love everybody else too, but thanks for making time to have a conversation with me. We also want to thank Eagle Feather News, Saskatchewan, sorry, Alberta Native News, CJWE, CFWE, CKLB, and Yellowknife Co-op Radio in Vancouver. Thank you, a million thank yous. And of course, the family at FNHMA and Nishnawbek Nation. We appreciate you getting us out there. And of course, our rebroadcast partners, NCI-FM Winnipeg, always Wolf 95.7, listen Sunday mornings at 9 a.m., CKLB and Yellowknife. Tune in on Thursdays at 7 to be rebroadcast, and Co-op Radio in Vancouver is Mondays at 12 Pacific. With that, a huge heartfelt thank you to both Doctors Evan Adams and Shannon McDonald for joining us and sharing their inherent knowledge. We thank you. Please stay safe, stay well, stay healthy, stay away, and we lift you up. Thank you. Hi, hi.
Emma, thank you.